no more PTFE membranes. So they were able to find a titanium reinforced one, which worked just the same pretty much. It definitely, you could feel the difference in the rigidity of it, which almost made it kind of harder, I think, because you had to like tuck it in under the flap, but it like didn't really want to bend appropriately, so that was kind of tricky. But got the fit nicely. Got one side tucked in, threw the bone in, tucked the other side in, and then did the modified horizontal mattress suture, and it turned out beautiful.
Yeah, it looked really good. I had the opportunity to pop in at several points during it, and it looked really good. Perfect tooth to do it on, your side of the chair, upper arch,
Yep.
it's not too far back there. No nerve to worry about. The sinus wasn't part of the equation.
A perfect first go at it.
Yeah. Maybe at some point we'll do the atraumatic extraction, because I think a few people here may not have heard of that approach. But the technique is essentially cutting the crown off and then making a mesial and distal trough on the interseptal bone of the tooth, and then using your elevators to go down that space. And what it does, it preserves the buccal bone and the buccal plate. It seems like a very traumatic extraction, which is funny when you first describe this to people and you say it's an atraumatic extraction. One might think it's a very traumatic extraction, but from a biological perspective, it's very favorable for maximum healing. So maybe it's more trauma, but it's more trauma for a better outcome in the end. We'll go over that at some point. But it worked out well, Chad. All right. Well, welcome everybody. Thank you for the repeated weeks of trying to figure out my technology. So I have a new laptop that, well, I say new. I bought it during COVID. I've never had issues with Macs. This is my fourth Mac in the past maybe 15 years, and they typically run really well, but apparently I got the lemon on this one. So we're all back up and running. Let's go ahead and share our screen. So Luke's on the other end. He's going to do the typing for us. We're going to do a treatment plan together. This was the one I had planned on doing many moons ago. So my goal here is to share multiple things on the screen. So let's see if I can do this okay. All right. Chad, can you see that okay?
Yes.
Yes? All right. Beforehand, I just want to quickly go back over this. I thought this was a pretty important thing. A few of you guys had sent things my way relating to this topic about pontic design. And we went over the different conventional kinds of pontics. But the one that I really want us to start focusing on when we do bridges and implant bridges is the ovate pontic, where we take advantage of a healing socket by putting a pontic in that healing socket at the time of extraction. One of the advantages to being a general dentist doing oral surgery and restorative at the same time is this kind of thing. So you have let's say you're taking out tooth number 4, 3 and 5 are going to be future abutments for a bridge. You would prep those teeth for your bridge, just like you normally would, and then you would take out the tooth and then cut off the tooth. Well, that's a different technique when we actually bond it to the adjacent teeth. In this case, you would just take the tooth out and then do a temporary bridge over that site. But what you would do is you'd add flowable on the underside of your temporary so that the tissue heals in this manner. And this is a very, very hygienic, phonetic, and biologically stable type of pontic. It's just difficult to do. So this is kind of what you can envision if you do it right. I got this off Google, but this is the potential if you do it really well. I'd imagine this is a final restoration, but definitely something that far supersedes the kind of pontics that most of us are used to doing when we just send an impression to the lab and they send back whatever they send us. So we had gone over that. We also went over last time the CIS protocol. I strongly encourage everybody to know this. well. Placing implants might not be something you do, but understanding if implants are infected or not is something we all have to know. This is a very simple flow chart that you can put in your clinical guide, personal clinical guide, that will allow you to understand whether or not you should refer to the periodontist, or you should do treatment, or your hygienist should do treatment. It's a very simple flow chart. And again, it's called the CIST protocol. The acronym is Cumulative Interceptive Surgical Therapy. Essentially, it's a bunch of meta-analyses studies that were put together into one protocol. So this chart has thousands and thousands of studies sitting beneath it. And that's where that acronym comes from.
Hey, Dr. Roy, I have a quick question.
Yeah, go ahead, Judd.
Kind of off topic, but related to this. So I saw a patient for like a hygiene check at my Winthrop office, and she had an implant placed a few years ago at an oral surgeon's office in Augusta. And long story short, had some probing depths and some bleeding. Is it more appropriate to send them back to where it was placed at the oral surgeon, or just to a new periodontist in that case? Do oral surgeons know how to manage a failing implant, or should I go to a perio?
Let me think how I want to phrase this. It's a really good question. So if it's been a few years, I'd probably send it back to the original surgeon, just because they're more likely to maybe redo it if it's at that point where it needs to be redone.
Yeah.
Or do something and not charge the patient. So I think you're more likely to get a patient-friendly outcome if you sent it back to the original surgeon. With that said, surgeons are not taught the level of care that a periodontist does. We all know the periodontists are the final carpenters, or the, what do they call that? The finishing carpentry, whereas the oral surgeon builds the house. They're both necessary, and they're both very good at what they do, but they approach things from a different angle. So if it's a situation where there's like a thread showing, or you have a deep pocket and no threads are showing yet, and it's been a little while, then I would probably lean to the periodontist, because they have more tools in their toolbox to potentially resurrect that implant, such as guided bone regeneration. With that said, the dental community, even the periodontists, are getting away from grafting around implants, doing things like threadectomies where they reduce the threads. We've kind of gotten good enough at quickly removing an implant, grafting, and then putting a new one in, that it's far more predictable to do that than to try to do these fancy techniques that cost a lot of money and have low predictability. With that said, I don't have a ton of experience in this world. I can kind of share with you a few isolated examples that are important. One is a periodontist placed an implant and for 10 years was just watching it, and it had a 6mm pocket that wasn't bleeding. That particular situation isn't on this flow chart here, but they just watched it, and it never got worse. I think I saw the patient a year ago, and it's still where it is today. So there's all kinds of differing opinions on this. So if you sent a patient to an oral surgeon and a periodontist, you're probably going to get 7 opinions, if you get my drift. So it's pretty difficult. But what I would say in general is, if it's a small thing that needs a lot of focus and attention, the periodontist. If it looks like something that just needs to be hauled out, then I think the oral surgeon or the periodontist would be fine. But you can't go wrong with sending it to the original surgeon. If they decide to watch it and it's something that you know better, then yeah, send it to the periodontist. I don't think that we're practicing outside of our expectations if we provide a recommendation for a patient to have a second opinion, even if we're not the expert in that arena. So, long answer to a very good question.
Nice.
Anybody else have any thoughts? I didn't want to spend a lot of time on this. I just wanted to summarize what our last conversation was about. So I encourage everybody to have that printed and sitting chairside or at your desk. All right, so here we have Jackie. This is the treatment plan that I want us to go over today. And what we're going to be doing is sharing the screen with Luke. currently looking for a program that will allow us to do this more efficiently. All right, so here's the treatment plan, TPP P2. This is our treatment plan workup or planning sheet that we use to gather our thoughts for patients when we do treatment plans. So what we're going to do today, looks like we're doing good on time. We're going to start with the patient's chief complaint, problem list, relevant medical issues, so on and so forth, and then we're going to try to come up with a set of strategies, 4 or 5 different ballpark options that will be sent to the patient. Page 3, which is the phase plan, we probably won't have time for today. I'm thinking we do that next time. So today our goal is to present the patient with a set of options. So Luke, patient's chief complaint. Let's see if I can bring this over here. Yeah, at some point I'm going to figure out how to center this. All right, there we go. So her chief complaint is that she's had a series of back tooth issues over the past several years. And in her mind, she thought that she had crowned all her back teeth. Well, we know when you crown back teeth, you don't necessarily protect them from, compromise down the road. But she was kind of like, look, I'm getting older. I'm not sure if I'm going to have money in 5-10 years. I'd like to not have these problems with my teeth. Over the years, she's had single tooth dentistry. She had a crown here, a crown there. I think we get a pretty good idea of the kind of patient she is. She's also the kind of patient that always did what her dentist recommended. And our goal here isn't necessarily to say that this approach results in better outcomes, but it's to focus on the fact that most of dentistry focuses on one tooth at a time. And this is kind of what happens. The patients reach a point where they feel like the ball is rolling down the hill faster than they can catch up to, and the game is almost over, and she's just getting that sense. I would agree. I would have agreed to this 20 years ago, but that's just because we look at things from a proactive perspective, not a reactive perspective. With that said, she's in a reactionary state. She's reacting to a set of problems that have arisen, and she wants to do something about it. Our goal as good clinicians is to catch these patients 20, 30, 40 years ago and say, hey, do you want to do something with your mouth so that when you're 70, you don't have to deal with the issues like Jackie did? So that's really the mindset. Are we in a reactionary state, or are we in a proactive state? We spend most of our time as clinical dentists in the reactive state. So this is a reactive case. We're going to have some cases where we go over them to look at what proactive would look like. So let's start going over based on this here. This is the iTero scan. What do we see as problems for this patient? And Luke will type them in. Luke, you might want to put it on small font just so we can get them all in there.
Multiple missing teeth.
Yep. When I do this, I always say to myself, when there's missing teeth, is there missing bone and missing tissue at the same time? The answer is often yes. It's kind of difficult to say from this image here. I have all of her photos here.
It's pretty class 2, division 1 occlusion.
Yep. So when I look at missing teeth, I'm looking for things like this. So I can put down now missing bone and missing tissue, just to try to stay in that line of reasoning. Whenever I see missing teeth, I go to those two next. So Luke's putting those down. Yes, I agree, Chad. Severe overjet. I tend to want to use more patient-friendly terms. Class 2 Division 1 is obviously correct. But here I would say severe overjet / overbite. Sometimes I'll even put them as separate items. And what Luke's doing here is he's defining it. So what we try to do when we write up the problem list is actually have a descriptor that hopefully gets them to understand the severity of it. So you can write severe overjet and they might understand what you mean, but until you actually describe it out, potentially using emotional words, they may not get the sense of the severity of it. Overbite, and maybe here Luke put this can contribute to back tooth issues. So when we have anterior disclusion or lack of anterior contact, the forces are sent to the back of the mouth, the posterior teeth. In some patients, they do fine. In other patients, they do horrible. And she's one of the patients that obviously has suffered from years of posterior destruction due to lack of anterior support. Can anybody describe mutually protected occlusion, which this lady does not have? Anybody want to take a stab at it?
I'm taking a stab at it.
All right, go for it, Andrew.
So mutually protective occlusion is basically trying to say that when we're trying to put a lot of force downwards and take bites, our back teeth are going to protect the front teeth from massive forces there. But when we try to do excursives, our front teeth are going to protect, and we preferably have the canines in our lateral movements protect the rear teeth from causing greater forces on planes that we don't want those forces on.
Dude, that was beautiful. Yeah. Perfectly stated. So the back teeth protect the front teeth, and the front teeth protect the back teeth. And what you articulated, which is probably the most important part of it, is when the canines are in contact, they are preventing the inclines of the posterior teeth from contact. You know, that's what we call balancing interferences. There are times when we want those, such as group function, but more often than not, those posterior interferences cause muscle imbalances and other forms of instability. Another point that Andrew made is when the front teeth take over the support, there's a protective mechanism built into the nathologic system which actually decreases the muscle activity. And if maybe you guys have done this, but I'm just going to use the exercise. If you bite down on your back teeth right now and feel your masseter fire, so you bite as hard as you can, and then you bite on your front teeth and feel that same muscle, for most people it's going to be significantly less when you bite on your front teeth. Our body's designed to not allow the muscles to activate on our front teeth as much as our back teeth. Most of us understand that. It's the guiding principle and understanding for the NTI appliance or any sort of anterior deprogrammer. We get the jaw forward so that our front teeth touch, so that we can turn down the muscle activity. Now, there are some people this doesn't necessarily apply to, and we see those people who destroy their front teeth regardless of this fact. But this is definitely a situation where mutually protected occlusion is missing. So what else do we see here? Sometimes we get into classifying the molar classification, the canine classification. That's more for us, so this is oddly enough somewhat molar class 1, but that's just due to I'm sorry, that's the second molar there. Yeah, so this is a pretty significant class 2 situation, both molar and canine. What about periodontal compromise? Can we see anything from this photo? I often look around old PFMs to see if the gingiva is red. We've had several, Libby had a case recently. He saw the patient this morning. He's doing a full mouth rehab on, and the tissue around her crowns was really bad, and he replaced the crowns and they're immediately better. And he's fairly far subgingival, so we didn't know if the gingival reaction was based upon deep margins, ill-fitting margins, or an allergy. Well, the first thing he did is remove the potential allergy, and she got better. So we ruled out biologic width impingement for that patient. But you often want to look around these areas here to get a sense of, are there any soft tissue reactions to existing restorations, severe gingival reaction due to plaque buildup. So I would say she's got some plaque buildup right here and some gingival irritation. So I would say, I don't know if I'd want to say poor oral hygiene on this patient. I think we can all assume that this is probably dry mouth, xerostomia, salivary hypofunction, however you want to describe it, from a patient in their 7th and 8th decade of life. So here I would just say plaque buildup contributing to gingivitis, or what you wrote there, Luke. So one of the things, and Luke, I love that you're doing this. It's almost as if we planned it, but see how difficult it is to write patient-friendly things. So I'll typically go through, write my problem list, and then go back over and, as Michael Scott would say, tell me like I'm a kindergartner or a first grader. I forget the exact quote, but the point is you want to pretend like you're talking to somebody that doesn't understand this at all.
Explain this to me like I'm 5.
Explain, see? Labani, I threw that out there. I just want to make sure you weren't washing your car again. And I threw out a Michael Scott reference that I knew you would correct.
I'm great at multitasking. The car was super clean that day. And I learned all about oral sedation.
There you go. We have some crowding down here. So let's put tooth crowding.
Is that a cantilevered ponta?
Sure is. It's a one-winged Maryland bridge, I believe. Yep. What they found over time is the two wings, one of the wings often separated because it created a high amount of tensile strength when you attach both wings. So at some point they started doing one wing. I've seen them where they have like a little rest seat here that's not bonded. I've never done one, but I thought that was a pretty cool idea. But the conventional wing Maryland bridge has a higher success rate than a two-wing Maryland bridge, which I know some of you guys know this. I just want to assume that bits of information like this that are important that we always bring up front and center, regardless of whether or not somebody knows it. Where this becomes a little bit tricky is the bond strength of gold restorations using the old bonding techniques far supersede what we can do with zirconia. You know, we're not going to do Emax here. We're not going to do a PFM Maryland bridge wing. So we have to use something like zirconia, and zirconia bonding is possible, but it's not something you would do clinically here. So Maryland bridge is, you know, I wonder if it's going to be around in the future. This technique using these materials is something that the modern dentist doesn't know how to do. I worked in an office right out of residency, and the guy knew how to do this stuff, and I remember him teaching it to me. It was like every step had, you know, so much potential, a small margin of error. The product had to be, you know, stored at a certain temperature, and if you kept it out too long, then it didn't work with the other bonding agents. It's very difficult to bond metals to teeth. They figured it out, and they did a really good job of it, but it's a different era of dentistry. So I'd be interested to see what we do moving forward with this. I think the answer is the implant. So I would put, I don't know if this is a problem here. We'll leave it. She didn't say anything, so I wouldn't say it's failing. It's been there for 30 years. What about this? What might this tell us? When in doubt, the answer is either occlusion or airway. Which one do we want to choose? So what happens when we have a compromised airway?
Mouth breather. Sorry.
Yeah, definitely a potential mouth breather, especially with all that plaque buildup. You know, that might be one of the reasons why she contributes to the plaque buildup. When the patient is, if they had a hard time nose breathing, they would be a mouth breather. But if they had an obstruction, which may or may not be in addition to a nasal obstruction.
Like thrusting their tongue, is that what you're getting at?
Yep, so tongue thrust. Whenever you see splayed teeth that are at this kind of significantly protruded angle and there's spacing between the teeth, I would always think tongue thrust. So let's take a look at her photos and see if we can get a sense of the answer is actually right there. Anybody want to pick up on
Palatal tori.
palatal tori?
And a high vaulted palate.
High vaulted palate. Yeah, so the tongue's not living in the roof of the mouth. We're kind of going down a rabbit hole here, which is good. The airway rabbit hole is one we should often go down. What contributes to this? So if the tongue doesn't live up there where it's supposed to be, then the palatal vault looks like this, which is a high palatal vault. We want to see a nice U-shaped vault. Tongue tie. So tongue tie is a very common undiagnosed condition where the tongue lives at the floor of the mouth and it's restricted so it can't live at the roof of the mouth. Now, there are situations where patients can thrust forward, but they can't thrust up. There's a variation to a tongue tie called a posterior tongue tie, where there's actually frenum, lingual frena, down in the posterior part of the tongue that prevents this upward movement from happening. Moral of the story is she's probably not nose breathing well because her tongue didn't develop a nice palatal vault. Again, palatal vault, the roof of the mouth, is the floor of the nasal cavity. So when you see something like this, you automatically know, just based on physiology, that she probably has a hard time breathing through her nose. Well, if she has a hard time breathing through her nose, she might be more likely to tongue thrust in order to open the posterior airway and also be a mouth breather. So there's definitely a high likelihood of breathing compromise here. So when we see this picture here, just remember this right here. This is a sign of a very significant problem that we tend to overlook. We might just say, oh, if I just put some composite right here and right here, I can close that. Well, that's true, but is this patient screaming for help? And the answer is probably. So recession, potential root surface decay. So maybe severe recession, just leave it at that. What about the size of these restorations? So she has some very large class 3/class 4 restorations on her front teeth. Is that a problem?
If we change the occlusion so we're having anterior contacts, it probably become more of a problem.
Yeah. I was thinking somebody was going to say yes or no, and you hit the nail on the head. It really depends. So in her current occlusion, she's probably not coming into contact with those teeth. I'd be less likely to recommend crowns on those teeth. If we, like Elena said, if we bring those teeth into occlusion, her muscles have never really spent a lot of time on those incisal edges, at least not in her adult life, since these have splayed forward. Depending on the degree of restoration to natural tooth structure, we may want to consider doing some restorations here. And that might be overkill, but it's something to think about. Another problem that tends to arise, and we don't really see it when we first do a treatment plan, but when you start placing implants, you start to realize that these little spaces where teeth tilt into the edentulous space, these are hard to solve. Do you upright the tooth with ortho? Do you extract it and graft it and then put some implants in? Do you do a bridge with a little mini Pontic there? You know, those are questions that you need to be able to answer. If a patient wants you to rehab their mouth, you're not going to just wing that. You really got to have full control over it. So what we like to do is bring up the CAT scan. So let's bring that up. So this is just a pan image, but you can get an appreciation of what's going on over here. This is number 2, drifting severely towards the number 3 location. So what did you write here? Spacing, not necessarily a problem, but needs consideration. I would put that as a problem. I would say tilted teeth getting in the way of predictable solutions. You know, it leaves the door open a little bit for the patient to wonder what we mean by that. So we've already treatment planned her for some implants here, as you can see. But what else can we see in this image? That's a problem. Again, we're focusing on problems.
Failing endo on number 30.
Yes. Let's take a closer look at that. Tell you what, I know it's there, and I'm glad you saw it. I wanted to bring up the PA, but for some reason this is showing up smaller than I thought. So in the meantime, let's take a look at this image here. You know, having the ability to see things in 3 dimensions completely changes how well you can treatment plan. So right now I'm looking at this image here. This image is a cross-sectional view to what you would see on a PA, and it's this line right here, looking at number 30. And it's not as bad as it appears. I mean, you can see a little bit right there. There's the mental nerve, or the IAN. I guess we're at before the mental nerve. So yeah, we do see a radiolucency there. Let's look at the distal root. Yeah, it's definitely there. I would make note of it. Not sure I would retreat the tooth at this point unless there were some symptoms involved. I would look at the PA and let the PA guide me here. We're also a little bit restricted on the resolution based on the fact that I'm remoting into the office computer right now. What else do we see? So if we were to put this implant in, what's that?
Sinuses.
What can we give that for a name? What's the dental term for that?
Pneumatized.
Pneumatized sinus. Sinus pneumatization is enlargement of the sinus, typically due to chronic allergies. The allergy of the sinus membrane brings in inflammation, and that inflammation destructs the bone. We also see that with smokers. In this case here, it might just be pneumatization due to tooth loss. Either way, I would just simply say inadequate bone in several areas that might require significant bone grafting. All right, so the CAT scan, we can see missing bone here. Generalized bone loss. We could spend some time looking at the joint, which I normally do, but for the sake of time, I want to focus on one other thing here. Here's her maxillary sinus. There's her nose, nasal cavity, nasal turbinates, or nasal concha, or concha, depending on where you learn from. The important thing here is there's very small air. It's a very small airway. Can you imagine air trying to travel through that? It might be difficult if you've never looked at these images to say whether that's good or bad. Take my word for it, she's not breathing through her nose at all. Deviated septum. So she's somebody that needs an ENT referral at some point along the way. And it's difficult when we're putting a large treatment plan together. We're trying not to overwhelm the patient. So we'll all do this in our own manner, but how I do it is I don't want to start a case unless I have all the T's crossed and I's dotted. I really try to build the value for the patient that the predictability of the work that we do is going to be directly related to how well she can breathe. Those posterior teeth may be affected from lack of mutually protected occlusion, but one could easily surmise that she's not breathing well through her nose, which contributes to sympathetic activity. When we don't breathe well, we freak out, is what our nervous system does. People who don't breathe well all day live in a sympathetic state. They're fighting for their life, is how we can think of it. Their muscles are on hyperdrive, and one of the muscles that shows the most amount of increase in tonality in sympathetic tone is the masseter. I just drew a very long flow chart, connecting lack of nasal breathing to increase in dental problems in posterior teeth. This has all been fairly well documented. All right. So that's pretty much it. I think we have enough items here that the patient gets a sense that they don't have a healthy mouth. When you do these, if you decide to use this tool, the goal isn't necessarily to be 100% accurate. Nobody's grading you on this. Patient has no idea. Use patient-friendly terms and write enough to get the patient to understand they need something more than what they've been doing. That's the whole point of this. It's not to submit this to your dental school advisor saying, how good of a dentist am I? Obviously, you can take some time with it. With that said, I think it's something that you want to be somewhat brief. You don't want to spend too much time because you should be doing a lot of these. As many of the doctors that work at the practice know, this can get overwhelming if you really take your time with them. I think the first several, you're probably going to do that just because that's what we do. And then you just kind of get to a point where you realize, I just need to get the message to the patient that they have a lot going on. All right, so here's her medical history. See if I can bring that over. All right, so she didn't really write a lot here. She's taking doxycycline for rosacea. She had a joint replacement. These are important, but not necessarily relevant to our conversation. So she doesn't have a whole lot going on. She had some vaginal cancer, obviously a concern at the time. But then we have snoring. So snoring supports our idea that she has a compromised airway. The more you do this, the more you're going to just look at teeth and go, she snores, just by looking at their teeth. Her overjet and the splaying of number 9 and 10, I pretty much knew that this was going to be a yes on her medical history. So snoring, that's pretty much it there. Patient's desires and goals. To not have tooth problems. To have a healthy smile with teeth that will last a lifetime. Good. All right, so now we come on to page 2. We've uncovered a lot of things that I frankly don't think I can do during a hygiene styled new patient exam, where we go in the hygiene room. Those of you in different practices, you may have an hour and a half with your patients and you have time to go through all of this. That's not how we run our practice. We feel that length of new patient exam is completely too much for a lot of people. For the right person, it's fine. We just do it a little bit differently, where we take the right person, put them through this process, and then we take our time uncovering all of the necessary problems that might exist. All right, so we come over to the strategies. In the video I did, I don't know, maybe a month or two ago, going over the details on this, I go into kind of the psychology of how to use this sheet. I will reserve that conversation for that video. It's on the NECADE YouTube channel. If you guys want to see it, I'll send you a link. But let's take a look at what we can do for her. Let's start with the upper arch. Always good to do one arch at a time, keeping in mind that they need to line up with the other. Are we going to address her occlusion in every one of the strategies? And typically, no. You want that first strategy to be something cost effective for the patient. So I used to do partial denture first, and then maybe if the situation presented itself, complete denture second. Now I do strategy one, I just call it removable options. Reason being, although a complete denture might be an option for her, I don't think I would recommend it. There are situations where patients have clinical presentations that warrant either one or the other. The pros, the cons, and the costs are going to be relatively the same. So our goal isn't to give the patient every single option that they possibly could have, but put them into categories so that we can start having a conversation about the upsides and the downsides and their relation to cost. So while Luke is writing the pros and cons here, I'm going to say that again. The goal of the second page is to connect them to the cost connect the pros and the cons of various strategies to the cost. Like the first page, we're not necessarily looking to get exact answers here. So the pros, the cons, there'll be stuff that we miss here. Once they select an option, we need to be very thorough about going over all of that. But we have to be mindful of time. And here what Luke is doing is he's trying to paint a picture for the patient of what a partial is like. And what we do is we try to picture ourselves seeing that patient for 5, 6, 7 adjustments of their denture or their partial after we deliver the partial. Much of my career, I never did a good job of making a partial sound as shitty as it is and an implant as amazing as it is. I kind of just said, here are your options and here are the costs. And they'd ask me, what would you recommend? And I'd say the implant. But I didn't really do a good job of articulating the good parts and the bad parts, and that's where the pros and cons list came in. So Luke just did a good job there. What are the upsides to partial dentures and complete dentures? Helps restore some function. It's quick. And the other one is low cost. Yeah, Luke, we're going to have to figure out how to do this so that we can both type at the same time. Go ahead and put 6 to 8 there again, and we'll leave it just like that. I think everybody's got the right idea. All right, so option 2 is crown and bridge. Could we bridge this and this here? Sure. Crown some of the teeth? Sure. Lower arch, we unfortunately don't have the opportunity here. That would have to be either implants or partial. But what we're doing is we're starting to build a story for the patient about options they have available to them. So let's call option 2 crown and bridge and partial. Sometimes we will do 2A and 2B, where we do crown and bridge everywhere except for the lower left. 2A would be a partial, and 2B would be an implant for that lower left area where everything else is crown and bridge. One can imagine there are an infinite number of solutions that we can have here. Again, the goal is to create a stratification of out-of-pocket expense for them, and you're getting them to understand that the more they spend, this isn't about the money, so I'm making it sound that way, hear me out, the more they spend, the more predictable and the better the options become. It's super obvious, but this sheet somehow speaks to them in ways that I was never able to do talking to patients. So while Luke's filling this in, anybody have any thoughts or questions? Not so much about the options. The goal of this isn't necessarily for us to argue about what to do for Jackie. It's for us to take a test drive with the treatment planning sheet. Christian, you've taken this for a test drive, if you're still there.
Yeah, what about it?
Yeah, what are your thoughts? Do you find this helps connect with patients?
Yeah, I do mine a little bit differently. So when I get to this sheet, I spend some time, and maybe this is just how I prefer to do it, but I actually try to put every single option they can do, and I write it out a little bit for them, because I found that patients always had questions off of like the 4 options. So I would just put specifically for them like what I would be doing, and maybe I can send them an example to the group afterwards. It's doing the same thing. I think it's just a little bit more detailed, and I found that patients at the end of that literally will tell me, I'm doing plan 2B, or I'm doing plan 4A. And then I don't have to then go work up another like detailed plan or kind of expand what that plan specifically means. I've already done the work at the beginning.
Yeah.
I mean, maybe I've just found that I get more fulfillment that way, / it's more work on the front end, but it saves me time afterwards when maybe a few weeks have gone by and I'm like, wait, what was I doing with that plan? Like, what teeth did they need restorations on again? I would rather just sit down for an hour, bust it all out, and then send it to the patient.
Yeah. One of the hopes that I have is that we all do things like that, and we present what works for us, and at some point we're probably going to update the way we do it as a group. With that said, we're all going to have our own ways of doing it, and that's awesome. But my point is that when we do it our own way, there's going to be ways that you do it that are going to contribute to the greater cause and understanding of it. The only thing that I would be personally is there's just so many options that you can put down. I found it hard to articulate with some cases all of the options without spending a lot of time on it. With that said, some cases lend themselves to it, and there's some patients that really need it. And I am interested in talking to you a little bit more, Christian, about it. I'd be curious. But the idea is that you're more thorough in the beginning. You don't necessarily have to do kind of that second phase where the patient will select a strategy and then we come up with a very strategic and detailed option.
Yeah, exactly.
Yep, I like it.
So maybe I can send the group an example of one. I'll pick a random one, but I do everything very similarly, but I actually break down the options a little bit more. I think Dr. Stocker does something very similar to me. He's like put his own little spin, and I think ours are very similar.
Yes, send it out. If you can, just white out the patient's information.
Yeah, we'll do.
Yep. Yeah, thank you for sharing. I don't mean to put you on the spot, but you're a self-proclaimed multitasker, so I thought you could handle it. But you've done a lot of this, so I thought you'd be able to contribute in some way.
Can I ask a question?
Yeah, go ahead, Elena.
Where do you guys include, like if they have to see a specialist for retreat endo or whatever, how specific do you include that and like cost stuff because it's out of practice?
Sure. I'd be curious to see what Christian thinks, where he gets a little more detailed in it. He might include it here. The way I do it is I really try not to get specific here with things like that. In my opinion, it overwhelms the patients if we get too specific. I'm trying to connect them to, I'm trying to find out how much can they afford. That's really my main goal with this particular sheet. As time has gone on and I've done hundreds of these, self-admittedly, it gets time consuming. You know, I go home and I have 3 of these in one day. I just didn't have the time, so I got much more abbreviated with it. That's just where I am now. I'm going to revisit this with Christian to see, you know, exactly how he does it. But what I do now is I get a patient to agree to one of these options, and then I do a very detailed plan. So let's say they chose option 2. I get them to tell me, how much can you afford? And I say something to the effect of, if you wanted me to build you a house, I would need to know how much you can afford. You know, something to that effect. We have all kinds of variations to that. But the point is that dentistry is really good at just presenting options and then telling patients, this is the only option you have, or this is how much it's going to cost. We have so many ways of solving problems. This, to me, helps to simplify it. Although it's complicated, it's simplifying a very complex set of solutions for patients to be able to digest it. And if we do a good job of being somewhat succinct in our pros and cons, the patient will literally come in, put this on the table, and they're going to say, I like option 2 or 3. You know, I like the pros here. They get it. When we put it in this manner, they definitely get it. Then I say, all right, you probably want specifics now. Now that I have an idea of the ballpark you want to go in, I can get you into the seat. That's a phrase I had heard at a Dawson lecture once. You can get the patient to the stadium and then the seat. They're 2 separate, distinct steps versus getting them in the right seat of all of the stadiums in America. In other words, you have to boil it down to a 10,000 foot view first before you go down and give them the specifics. Now, I think what Christian's saying is he kind of does both at the same time, which is great. I just don't know how much effort that takes on his end, but he's probably efficient with it. The reality is this kind of presentation gets the patient to understand that there are cost-effective options that come with unfavorable cons, and the best option comes with a lot of pros. That's kind of the goal we're looking for.
To answer your question on, I'll put specifically in a plan, would recommend seeing the periodontist for these gum grafts for, fixing some fractions or some recession. And usually I'll put a question mark for the price, or I'll Google it and say, what's the gum graft per tooth per periodontist, and I'll put approximately $300 per tooth. And then during the consult, I tell them, again, I can't speak for these prices, but this is a general average. So that way they know, okay, when I go to the specialist for an endo retreat, I'm probably thinking this ballpark. I haven't had any flack on that. And they actually appreciate saying, okay, thanks for letting me know what I can probably expect.
Yeah, good stuff. Yeah, as we each do this, we're going to find comfortable ways of doing, communicating with patients. And there's different patients I do this differently for. So you really get an opportunity to get your thoughts on paper. I mean, the whole point of this is to treatment plan outside of the chair. The more that you do that, and the more you get your thoughts on paper and you write down your options on paper, the more clear you're going to be in the options available to the patient. So Luke was putting here comprehensive number 3. We're running up against the hour. I would like to pick up where we are right now. Christian, maybe next time you can present your version rather than email it. We can have you throw it up there and you can go over what you do, and then we can pick back up where we left off.
Sounds good.
All right, everybody. We had a successful technology alignment tonight. This is really good. My computer didn't die. The camera worked. All is good. All right, everybody have a good night. I'm going to watch 1883. If you haven't watched it, it's really good. The
Thank you.
prelude to Yellowstone. All right. Have a good
Good
night.
All right.
Bye.
See you guys.